This is the scan of a patient with the right-sided maxillary carcinoma. As we scroll the eggshell scans from down up, we see that there is a right-sided level 2 node close proximity to the IJV showing partial necrosis. As we go higher up, there is an ulcero-infiltrative lesion involving the right upper GBS eroding the floor of the maxilla, that's the alveolar process, posteriorly eroding the pterygoid plates, lower half, and involving the origin of the medial pterygoid as we see here. But the origin of the lateral pterygoid muscle looks clear. When we go on to the coronal section, which gives us the actual height of the involvement of the tumor, as we trace it from front back, we see that the ulcer-infiltrative lesion is involving the upper GBS going down till the lower GBS, no bone involvement of the mandible, but there is erosion of the alveolar process and the pterygoid plates lower down, but the medial and the lateral pterygoid muscle near the insertion looks normal. So this is a case of a right-sided maxillary primary which is eroding the floor of the maxilla and extending into the upper GBS. So the plan is to do an orbital plate preserving maxillectomy. The scans show the disease is involving the pterygoid plates, lower half, and involvement of the origin of the lateral pterygoid muscle and the medial pterygoid muscle. So the plan would be to take the pterygoids right from the base, if required, drill the base. That incision and that extension is not possible through a sublabial approach, so we will take a classical lateral rhinotomy with a Diefenbach extension. What we have marked here is the lateral canthus and the tragus. So the line joining the lateral canthus and the tragus is the approximate landmark for the orbital branch of the facial nerve. So our incision should actually end proximal to that line, and if we are elevating the flap in a plane above the periosteum, we should be very much concerned about crossing this line. If we cross that line, there is a chance that we might damage the nerve. There is no erosion of the anterior face of the maxilla, so we are going to take the flap subperiosteally till the line joining the lateral canthus and the tragus. So this is the intraoperative picture. We can see that there is a lesion which is coming from the last molar region extending onto the upper GBS. The teeth are mobile here. The second last teeth is mobile. There is a soft tissue mass which is involving the upper GBS, but the lower GBS appears free. There is no significant extension onto the soft palate hard palate junction, so we can actually go ahead and take out less than the hemipalate in this case, such that we don't have to cut the nasal septum on the same side. We have packed the throat. So we have taken the mucosal incision and we have deepened it, taking the muscle. We have also identified and ligated our facial artery here. Now since it is not extending close to the midline, we have taken our palatal cut, a tentative palatal cut at the junction between the canine and the lateral incisors. So we will be able to preserve the arch of the upper jaw. If you see, we have marked the incision onto the palate, extending onto the soft palate. The only reason being we have not deepened the incision is because we have not ligated the internal maxillary artery. Unless and until we do that, the greater palatine will start to bleed and there will be necessary blood loss. The whole idea of doing a maxilla surgery is to reduce the blood loss to as little as possible and to identify the critical structures, because once it starts to bleed, none of the structures will be visible, and the only way to reduce the bleeding or to stop the bleeding would be to remove the specimen as early as possible. And in doing that, there is a chance that we might compromise the margins. So always, as far as possible, take the mucosal cuts first, demarcate the mucosal cuts, and then go ahead with the skin incision, and then one by one go ahead with your osteotomies. So as you can see, we have given the mucosal incisions in the oral cavity. Our determined bone cut on the upper alveolus part would be in between the lateral incisor and the canine. We have not opened up the columellar area. We have opened up the nasal cavity on the right side. So instead of taking the dip here, we are going to take out directly. The bone cut would be directly from the, not from the crest, but on the anterior face of the maxilla going on to the alveolar process. We have delineated the nasal bones. We do not take the nasal bone. Generally, when we take the nasal bone in radical maxillectomies, since this part of the nasal architecture is gone, there is no support for the skin flaps. There is always a fistula which forms here. So instead of that, we are going to preserve the nasal bones. We have delineated the orbital plate. Now we have taken an incision. We have identified the orbicularis oculi muscle. We have separated the muscle from the skin flap, and this is the orbital plate. So basically the skin incisions now are done. We are going to take an osteoclastic flap, elevating the entire skin complex from the periosteum down laterally. Identify the zygoma, identify the masseter muscle, detach the masseter muscle, identify the temporalis muscle, detach each fibers of the temporalis, identify the internal maxillary artery, clip the internal maxillary artery, and then we'll go ahead with our bone cuts. So we were elevating the osteoclastic flap, hugging the bone. This is the orbital floor, the rim of the orbit. And now this is the infraorbital nerve complex. So like I was telling, whenever we are doing an osteotomy on the anterior face of the maxilla, which is below the infraorbital foramen opening, we call it an infrastructure. And once we are crossing that, we can call it as an orbital plate preserving. And once we take on the orbit, that becomes a total maxillectomy. So this definitely will be resected. So we will ligate this, cut it, and then continue our elevation further. So we have elevated the flap. We have detached the temporalis from the zygoma. We have delineated the cut of the marginal here. This is the buccal pad of fat, which will serve as an extra margin. And now this is the coronoid. Since we have opened up the mouth more, the coronoid has displaced anteriorly, and now will be gradual dissection of the fibers of the temporalis of the coronoid process, and identifying the IMA here, clipping it, and then taking the marginal cut and the rest of the bony cuts. So now we have elevated the osteoclastic flap. Now this is the infraorbital nerve along with the vessels which we have ligated. This is the zygoma, anterior face maxilla. This was the mucosal incision, deepened down till the muscle, and we have kept a soft tissue, another soft tissue margin beyond the muscle. You can see the fat here. The reason because the buccal mucosa lesion would need an extra about a centimeter base. This is the buccal pad of fat which had dropped out. Now if we see the zygoma, this is the origin of the masseter muscle. So now the plan is to detach the masseter. Part of the masseter which we are going to detach will form part of the specimen which will come along with the coronoidectomy or the marginal mandibulectomy. Once we detach the masseter, in fact we are still able to palpate the coronoid. We'll open the mouth more, displace the coronoid anteriorly, detach the temporalis, gradually identify IMA in between the coronoid and the condyle, clip the IMA, and then go ahead. So now what we did, we had detached the temporalis from the coronoid. So you realize we get a good amount of space. Gradually we went on detaching the temporalis muscle, individual fibers by fiber. We had gone right till the depth. We palpated the condyle, coronoid and the sigmoid notch, and right near the condyle we identified the internal maxillary artery, which we will clip now. In this area, any structure which feels like an artery needs to be clipped, because once it gets retracted, because of the limited access, it is difficult for us to catch that structure again. So ideally all structures which resemble an artery vein needs to be clipped and cut. So instead of cutting, we'll use a bipolar irrigation, please. So we have done with our soft tissue elevations. Now the only thing pending will be the bone cut. So the first bone cut is going to start from the ascending process of the maxilla, going down on the alveolar process of the maxilla.
not in the midline, so no need for the step directly down from the apex of the pyriform aperture down onto the alveolar process. A second bony cut would be along the nasal bone. Since the nasal bone need not be resected in entirety, we will keep the nasal bone such that there is support onto the edge which turns at the medial canthus, such that there is no OC fistula, no nasocutaneous fistula. The third cut would be preserving the orbital plate above the infraorbital foramen. The fourth cut will be at the zygoma, where the zygoma meets the maxilla. This, and then we will do the marginal mandibulectomy. Once we have done with this cut, we'll hinge our osteotome and we'll just down rotate the entire specimen. When we do that, if all the cuts have been taken well, most of the walls will fracture except for the posterior lateral wall, which is attached to the pterygoid base. Once we do that, we can actually see the postlateral wall from the opening between the orbital plate here and the down fractured part of the rest of the anterior face maxilla. Hinge our osteotome at the superiormost edge of the pterygoid, give a hammer cut onto the osteotome such that it down fractures and that part of the maxilla also comes out. The only other attachment would be the soft tissue, which would be the medial and the lateral pterygoid. So the plan first is to detach the lateral pterygoid, which will be done through the same opening here. Slightly difficult, but could be possible. And once we have done the marginal mandibulectomy, we'll detach the medial pterygoid from the insertion onto the medial aspect of the mandible near the angle. We're going to do the first cut also at the anterior edge of the pyriform sinus or pyriform fossa opening, and the cut will come So the second cut now is what we are going to take onto the palate, paramedian on the right side, that's the same side. We have detached the hard palate, soft palate, and we merge the palatal cut with the cut which we have taken on the alveolar part of the maxilla. So now the third, the fourth and the fifth cut will all be taken together. This is the infraorbital foramen opening. This is the orbital grid. We are going to preserve the orbital grid. First cut would be from the nasal bone, curve it along the anterior face and then onto the zygoma. Okay? We'll keep our suction in such a way that it will always protect the globe. And then the direction will change downward. So we have taken the cut with the saw, just confirming the cut is complete or not. So the first cut's done. Sure. So second cut, and the continuation of the first cut. So it's separate from the piriform aperture. Now we will continue the cut which we have taken in the nasal bone. Suction please. Turning the head a bit towards the opposite side. This is our cut here. My instrument is able to pass through completely, and it is. The specimen is moving here. Same way at the lateral edge. Everything is stereogoma. We just have to be gentle, not to extend the cut up or to fracture the orbital plate. All cuts are directed away from the orbit. You see, this is mobile now. Our lateralmost edge is at the junction of the maxilla and the, sorry, able to see now? Okay, so now, center. So now when you rotate this, the maxilla down fractures. Okay, still remember we have not taken the cut on the posterior wall. That is still pending. We have detached this maxilla, the residual maxilla is still attached here. So we'll cut this. We'll cut this, and then once this drops down, we'll suction the edge of the bone well. We'll down fracture it more. At that point, we'll be able to see the interior of the maxilla, the posterior lateral wall, and then take our cuts on the posterior lateral wall under vision. Like this. Suction please. So this is how it down fractures. Okay. Even though we have not taken our incision or bony cut on the postlateral wall and the pterygoids. Thank you. So most of the bony cuts done on the maxilla. We are left with just doing a marginal mandibulectomy. So we have started doing a marginal mandibulectomy. This becomes a slightly critical structure or critical bony cut because the angulation is difficult. We have already taken a cut on the first molar region, and now we are extending the cut backward towards the coronal. Care to be taken that we keep sufficient sum down as well as to not fracture the conduct. Okay. Tap the marginal mandibulectomy. This is the bone edge. The entire bone is now free. If you can see, we have taken it right till the coronal. So the mandible, the marginal part is completely free. Now we had taken the specimen or rocked the specimen downwards. So I wanted to show two things. This is the intraorbital nerve, and there is a groove through which it is running. This is the residual orbital floor. We have actually stripped off the mucosa from the orbital floor. And now, for the final cut, we will see the slope of the orbit, and exactly at that level, this is the lateral, posterior lateral, and the posterior wall. This will be down fracture. We have taken a cut on the medial wall above the inferior turbinate, taking care that we have taken off, spreaded off this wall. In an ideal maxillectomy, this specimen rotates laterally. The last mucosal cut is the one which we take at the level of the just anterior to the eustachian tube. So that would not be required here. or even if required, that would be the last cut which we will take, the last mucosal cut. So we have done the bony cut on the mandible, and we were just separating it off from the floor of the oral cavity. A blob of fat opened up, so that's the parapharyngeal fat pad, and our aim was to detach the medial pterygoid from its insertion. So now this is the parapharyngeal fat pad. This muscle, which is getting inserted onto the angle of the mandible medially, becomes the medial pterygoid. So we will detach the medial pterygoid from here. We have all this specimen is already mobile. We have taken the cut, which we will show you later, on the pterygoid base. So once the medial pterygoid has been detached, the specimen has to rotate. Once it gets rotated, the last cut would be along the nasopharynx, just anterior to the eustachian tube opening. So we have done with most of our bony, almost all of the bony and soft tissue cuts. Now the only thing pending and holding the specimen behind is the whitish structure which you are seeing here. That's the nerves which are coming out from the foramen ovale. Okay. And if I just focus here where my suction is, that is the residual pterygoid base. So now the only structure which is holding the specimen, the nerve, already been clipped. We will cut it and the specimen will be delivered. So this is the final specimen, anatomically like this. Upper alveolus, lesion in the right last molar T, second last was mobile, buccal mucosa. This is the muscle along with which soft tissue has been taken. Buccal pad of fat, which serves as an extra margin. Marginal mandibulectomy with masseter. Temporalis. Maxillary sinus with the opening of the lacrimal duct. This pterygoid plates at the base, medial pterygoid muscle, lateral pterygoid muscle. The entire skull base has been removed. This is the nasal cavity, and we are this far away mucosally. Thank you.